Designing a medical record to work offline is actually a lot more complicated than it first appears. And what I would like to do is first explain the problem in about 30 seconds and then go through a much more detailed explanation of the problem and trying to unpack that. My hope is that maybe someone listening to this presentation will be able to help assist us as we work through this problem and try to come up with a solution which addresses it. Here's the problem in brief. We run a medical record in a Google Chrome browser on tablets and desktops in different clinics. These devices are connected to a router that transmits a signal through 3G and 4G cellular through a VPN to our server. The router, the cellular, and the server can slow down, stop working, and when the power is unstable, it can be unreliable or malfunction. And so we want to build a more robust system that will allow a clinic to continue to function and remain locally in sync, meaning the devices within that clinic will remain in sync, even if the cellular, central server, or even the local router malfunctions. And then this clinic would resync with the central server when the connection is restored, typically after 5 minutes or a few hours later. And that's kind of the problem. The side problem with this is that our users are merciless about the system speed, and they really demand a fast and responsive electronic medical record. And the only way that I see being able to deliver on this request is to build using offline first methodology to take advantage of pre-caching the medical record. So why don't we just go into this problem in a little bit more detail, trying to think about exactly what our current infrastructure is, some of the challenges we have with that infrastructure, some of the different possible solutions. I think there's about 4 different ways that this can be solved, each with its own advantage and disadvantage. And then we'll end by looking at what I've kind of invented as what you could call levels of offline functionality in medical records, trying to define how a system can be more advanced in its offline capabilities. I am by no means a network system architect. In fact, I don't even pretend to play a network system architect. So if I say anything or if you hear anything which sounds really stupid, it's probably just because I don't know what I'm talking about. All right, let's look at the problem here in more detail. So the hard part of this project is that a patient's chart must remain synchronized between all the users within a clinic, and that clinic must also remain in sync with a central server. Now, this is different from most offline projects where one individual device needs to store and cache data for an offline state, and then that one individual device resyncs with the central server when connectivity is restored. And the reason that the devices within a clinic must remain in sync with each other is that as a patient goes through a clinic, they see different clinicians, each with their own device. For instance, you may check in at the registration desk, then see the nurses, the clinical officers, the consultants, the nutritionists, the social workers, the pharmacists, etc. So each subsequent encounter within that clinic requires the information from the prior person. And trying to create a real-time sync at this local level, even if you lose the router, the cellular connection, or your server, is actually a really tough problem to solve, or at least using traditional methods and techniques. So very quickly, let's look at our current infrastructure just to clarify it one more time. First, again, the electronic medical record runs inside of a Chrome web browser, and this is rendering an Angular front end. The devices that we use are primarily tablets, and that's because they're low cost and they can operate for many hours on battery power. And some other sites are also using laptops and desktops. These devices within a clinic are connected to a clinic router and access points. And the router is supplied by a backup battery, which is solar charged. Sometimes the power may go out throughout the week at these remote sites for several hours at a time, and that's why there's this backup solar-powered battery. The site, the actual router has a spot for a SIM card, which is connected through a 3G and 4G network through a secure VPN from the remote clinic to the central server. And the central server is connected at a few sites. A few sites connect to that central server using a VSAT or a satellite internet connection, but most are through a cellular connection. Then the central server runs multiple applications on virtual machines and renders the electronic medical record. Now, why don't we look at the challenges of this setup, again, going maybe from the device all the way back to the server. So at the device side, speed is crucial to our users, and they mostly benchmark how fast the operation, the system is responding compared to how fast their apps on the phone open and close. And that's because many of our users are not familiar with desktop computers, and they certainly weren't using computers years ago when they were slower. And so we have a very, very high standard on what is considered a acceptable level of speed for the system. The second issue is that we use a cellular network, and sometimes that connection can be dodgy, for instance, in a period of heavy rain or if there's intermittent connectivity in a remote area. And to have an outage of a few seconds is not uncommon, and even this can cause system performance delays or irritate users. But if we incur outages of several minutes to several hours, this is unpredictable and brings the entire clinic to a halt. The clinic router and the access points can malfunction, and this can require them to be replaced, which, again, will bring a clinic to a halt for a long period of time potentially, as we need to ship both new hardware as well as a technician and deploy them to that remote rural site. At times, the router may malfunction because of a battery failure. The clinic backup battery, the solar wasn't charging perhaps properly, or the generator wasn't charging. And the reason that we use a router and that we don't install a SIM chip in each device is that the cost to install so many hundreds and hundreds of SIM cards in all the devices would both be very expensive for the cards, and then we'd also have to ensure all the devices have a SIM port, just raising the cost of the entire system. Now, one of the other challenges is that we have mobile clinics, and it would be really nice if these pop-up clinics could remain in sync with the devices at that clinic without having to bring modems, backup battery power, and other hardware. We really want a simple solution to deploy. At one point, there was remote servers at some of the sites, and the problem is that there's several issues with the use of remote servers or at clinic site servers for the current infrastructure we have. It adds obviously more costs to trying to scale this to new clinics. It requires more network IT personnel on the ground at remote sites, which is difficult to repair and maintain multiple servers. As we've been discussing, power is an issue, and it's unstable, and sometimes the solar-powered backup battery is insufficient to power additional small servers at these sites. Of course, you begin to run into issues with merging and conflicts as you add more offline servers to a network, and in that way, a real-time cellular system is easier to maintain version control. And just the practicalities and the way that the software is structured, it currently runs on multiple servers and multiple virtual machines. And this really requires a data center or data stack to coordinate and deploy this. And you can't really replicate that easily in multiple remote servers in its current form. And finally, last, getting to the actual central server itself, that server at times can slow down. For instance, during peak usage in the late morning hours when many people are on the system. As the system grows and more users are expanded, that also puts additional load on the server. And if the server crashes, which fortunately is very rare, that can bring down the entire network of clinics. There's 4 different possible offline solutions that I would like to go through. Each of these has some benefits, but they also come back with some drawbacks. And as I say, ultimately, we're looking for something that is reliable, scalable, and very simple, because the wide geographic network which this system is deployed over really can't rely on IT personnel at the sites on the ground. So the first option is to deploy a local server at each site. And the way that this would work is that the devices at that site would interact with the local server the same way they were previously using the central server. The local server would then synchronize to the central server. In many ways, though, this is probably the least desirable solution, because all it does is bring in new problems while providing very few advantages. The problems being that if that local server crashes, the clinic crashes too, and this just adds another IT device to now maintain. We have to additionally power this device, and we still have some synchronization data reconciliation issues between the local server and the main server. One of the advantages is that all the tablets in the clinic have one source of truth, as they're all talking to one server to verify the information they need to look at. And in theory, those devices could still update that local server even if the cellular connection or the central server went down. So that's an advantage there, but the problem is that if that local server goes down, the entire clinic goes down with it. And so we've kind of just displaced the concern of the central server going down or the cellular connection going down to now replacing it with the problem of the local server could go down. So we've just moved the issue of the server malfunctioning from the central location closer to the actual clinic. We'll move to option 2, which is a progressive web app or an offline first approach. In this case, the tablets and devices would use their local cache to store information. Each tablet and each device would talk to the central server as they currently do, but they would use sort of a progressive web app approach or offline first approach to always download to their local cache the information required. The big problem with this system is that it doesn't allow multiple devices in a clinic to remain in sync at once. And this is a huge problem from a workflow perspective. There's also some questions about how do we allow our server-side applications to now run on these devices in an offline state. My understanding is this isn't impossible, but we need to think it through. There's a lot of advantages to moving to a progressive web app framework or an offline first framework. In fact, I'm a strong believer in offline first and think that pretty much all websites should be designed with offline first mentality, even in high connectivity environments, because the big advantage with offline first is that the website stores to the local cache the data it requires for that page. And it can check the local cache by default first rather than pinging the server. And this really allows the speed and performance and the responsiveness of a website to be quite incredible from the demos that I've seen online using this type of technology. And the other advantage is that this is becoming more and more mainstream and more well supported. You know, in our case, all of our users use Google Chrome, which has, of course, led the way in progressive web apps, and so we don't need to worry about the few browsers which still haven't brought this technology in. One of the other advantages is that it does have the potential to reduce the number of server requests as more information will be stored on the device's local cache, and this potentially could help aid in issues of peak usage at peak hours, although it doesn't entirely get around the issue. The third option is a combination of the first option, the local server, connected to the progressive web app. So the thought would be that you would end up building a progressive web app, which would then connect to a local server. And so if the local server malfunctioned, that the tablets could then still have an offline version of the patient's data on the device, but the issue is that these devices don't talk to each other. And so we still get into that same problem we had at the start of how do you allow multiple devices within a clinic to remain live in sync with each other, even if that local clinic router or local clinic server malfunctions. So option 3 is kind of a hybrid of these previous two options and brings with it all the problems of both of them combined. I'd like to now look into option 4, which I think is the most exciting option we have. This is essentially an offline peer-to-peer system or an offline mesh network. The devices in the local clinic would remain in sync with each other, and this local clinic would then be able to synchronize with itself when possible with the central server. At times, if we wanted to increase the capacity for offline or historical data to be retained within this local mesh network, we could add a small server or desktop with a larger hard drive, which could then increase the cache within the local mesh network. But this isn't required in all instances. And when we talk about designing an offline mesh network or an offline peer-to-peer network, we need to mention that this is also incorporating option 2 and the progressive web app infrastructure, that offline first infrastructure, meaning that you would be able to continue to use the tablet. If the tablet lost connection to the router, the cellular connection, or the central server, you would still be able to continue to access historical information which is stored on the tablet's local cache. You'd be able to continue to update information in the forms that you're collecting information on. And so that's all that concept of progressive web app or offline first. And then because we're combining the offline first technology with a peer-to-peer technology, as you update the information on your tablet, it would be in real time updated across the other devices in your mesh network. Now, you could connect to your other devices using whatever transport mechanisms were essentially designed for, whether it's Bluetooth, wireless, and ideally you could probably just push through WebSockets in theory. But this seems really hard to build. Admittedly, this idea was Thomas's, and when we were first discussing it, we weren't sure if there were any instances of people using these technologies at any scale and with any reliability. Obviously, people have been working on this, I know, in experimental phases, in Indian parts of Asia, these types of networks, but I haven't actually seen it in success. So that's the real question. The problem is, does it work? How does the data get reconciled? How does the data sync? I mean, it has many advantages. The devices in the clinic can remain in sync. In theory, it doesn't require new network hardware. It doesn't require network IT support. It's impervious to problems in the cellular, the power, the server, and the network. You have the benefits of an offline first approach. You're able to use it in very small clinics or very large clinics, and the whole system will reduce the number of queries to the central server, meaning that the data bundles for the cellular network will be lower, and you can reduce your central server load. What I would like to do right now is just take you through a few different ideas on what I'm calling levels of offline functionality for electronic health systems. And this is just the first iteration of this, but the point is to show how one could design a very simple offline solution and potentially the steps you would need to take in order to add more and more functionality to that. And each step, of course, builds on the previous step. So the first step, or level 1, would be offline data viewing. When you lose network connection, you can continue to use the data which is on your device's local cache to view a certain amount of the patient's historical data which has been cached. The problem is that I actually can't imagine in our clinic workflow where exactly this would be useful, because almost always in clinics, we are also collecting information about the patient, which brings us to level 2, which is being able to, on one single device, do a two-way sync, meaning that we can collect data on a patient, store it on the local device, and then resync that data back to the central server when connection is restored. So that's one way of the sync. And then we also include the sync from the previous level 1, where we're able to view historical data which has previously been saved onto the device. So one example would be, for instance, if you were taking a device, a phone or a tablet to a patient's house, and you were collecting a limited amount of information on the patient. If you were collecting information about a patient and their house, you could view a limited amount of their historical information on the device. You could collect the information at their house in an offline mode, and then the device could resynchronize back when you are in network range. Another example could be that if a clinic was entering information in a retrospective manner, they work on paper in clinic and then they enter that paper afterwards into the medical record through a laptop after the clinic, you could have a limited amount of information on that laptop so that you could search for a patient. You could open up a form and then you could enter that information into the form. And then when that device was brought back into a network area, it could resynchronize. The next level, level 3, is where you would have multiple devices in an offline network with a small sync history. So this would, for instance, be if you go to a screening clinic, you might have a device for the registration desk, a device for the blood pressure screening clinician, the clinician doing cervical cancer screening, the person doing mental health screening. And these 4 devices would be able to easily remain in sync with the information that they're collecting during this pop-up clinic. That if you want, you could even have a lockout, meaning that the patient's charts, which are being accessed on these devices in this clinic, could be locked out from the server, meaning that no one else could access their chart while the chart is currently in the offline mode in this screening clinic. And then the screening clinic devices would have a small amount of those patients' historical information. But the primary role of this is to be able to do real-time data collection with multiple devices in sync in an offline mode. We move then into level 4, where you have a multi-device offline network with a medium sync history. For instance, this could be multiple devices at a small dispensary, where in this case you want to have more historical patient information available in the offline mode. And you may also want to have several other users, such as a pharmacy, within this clinic's real-time network. Level 5 is the multi-device offline network with a large sync history. So this would be, again, having multiple devices, in this case at a large clinic, and you would want to have access to quite a lot of historical patient information if the clinic had to operate in the offline mode. I would also suggest that because different clinics require access to the chart at the same time, you probably would want to not have to use patient chart lockouts in order to allow this option to work. And so it would require more advanced methods for merging conflicts and managing more users. Level 6 is a multi-device offline network with a large sync history, so the same as level 5, but in addition we add real-time ancillary services. And by this I mean that the patients within this clinic are having labs and other tests such as imaging or insurance, which are being reported in real time into the patient's chart. And so it would be very important that the system is able to incorporate new information, sync this in real time And of course, it may need to be synced with the central server. If the lab, for instance, is in a different building, that lab would then have to sync to the central server. Then the central server would have to sync to the offline, to the multiple devices in the large clinic. And the key part here is that large clinic would need to know, for instance, when data is outstanding, when there might be a lab report which was ordered but hasn't been reported back yet. And it would be very important that the way that the medical record is structured is that you always knew when you always know when you're in an offline mode and the data you're looking at may be inaccurate and not an accurate reflection of the current online state. We move into level 7, which is trying to wonder how could you synchronize this across a larger institution, such as an entire hospital with intermediate connectivity. And the last question, it would be level 8, a whole county. How could you make a peer-to-peer offline health network throughout a county? And I haven't thought through more details on that part yet. I include in the online post a very rough example of how these different levels may need to access different amounts of historic data. The numbers in here, 1 through 5, indicate the number of years of historical data to save at that level. In this chart, the number 6 indicates all, or everything. So for instance, if you were building a level 2 offline system, that was one which you have a single device which you're trying to do a two-way sync on, and you might be using that to collect patient information going door to door, you would require the user to log in. You would need to be able to search the daily clinic list, but you don't require being able to search for any patient ever that exists. You don't require all the patient's past demographic information. You may only require 1 year of recent encounters or vital signs, perhaps only the last few months' worth of medications. And as you can see in this example, as you move to a level 3 or a level 4 or a level 5 offline functionality, you increase the amount of offline data captured in each of these fields. So for instance, you may want to, in a level 1 offline functionality, only have 1 year of vital signs. In a level 2 offline functionality, have 2 years, and everything which is considered level 4 or above, such as a small dispensary, should always have all the patient's historical vital signs. This was just a quick example to demonstrate how we need to think about all the different components within an electronic medical record and try to understand exactly how much historical data of each of these components will need to be cached depending on the level of complexity that one is designing for the offline state. And so the question, what is the solution? Well, we're still in the research and experimentation phase. We're looking for answers, suggestions, and advice. I want to thank those who have contributed to trying to solve this problem quite sincerely. I've been really impressed with the suggestions, and many of them in the area of offline mesh networks. They're doing things which I did not think yet were scalable or possible in this area, and I'm very excited about what we might be able to do. Admittedly, I don't know when we'll be able to post the follow-up, which is the solution post to the offline mesh network. We'll see where that goes. And again, I'd like to thank Dr. Thomas Mogi for his insights on really trying to frame this problem and the possible solutions one can look at. I think it's an exciting problem to work on, and it's certainly not one which is only limited to healthcare, but to quite a number of different applications. And last, if anyone has any suggestions on how we can improve the concept of multiple levels of offline functionality for electronic medical records and really flesh out this idea in more detail, I would love to hear from you. My email is in the description for the podcast or YouTube video. and on the website.